Good. Hopefully this is it. Weird to get. So you can come at the end.
Oh, I haven't.
We're working on the numbers of young people, and I will get back to you. Sure. Great, and good morning, and welcome to everyone. This is the official AIDS 2018 press briefing, our first of AIDS 2018, and I'm delighted that it's about prevention. I think that already says a very important message we want to get out at this conference. My name is Linda Gale Becker. I'm president of the International AIDS Society and the International Scientific Chair of the 22nd International AIDS Conference, also known as AIDS 2018. I'm also a professor of medicine. I come from Cape Town and I work at the Desmond Tutu HIV Center. This briefing is being live streamed on the AIDS 2018 virtual conference page, and an archived recording will be available there afterwards. I'd like to extend a warm welcome, therefore, to those of you who are joining us from around the world. We're calling this briefing HIV Prevention Research Highlights. And I think there are some really terrific highlights. Today's press conference will highlight 5 prevention studies, including updates on the progress of HIV vaccines, innovation in digital tracking technologies to improve PrEP, new data on the effectiveness of on-demand PrEP amongst MSM, data on potential interactions of PrEP and feminizing hormone therapy, as well as new research on the effectiveness of viral suppression for reducing HIV transmission among men, gay male serodiscordant couples. These studies include, I think, cutting-edge research, many of them late-breaking, that advance our knowledge on many fronts, and in these cases will have important real-world implications. They point the way towards our implementation and practice in the field. I'm pleased to have several wonderful world-renowned experts joining me here today to discuss this, because as the world's largest open gathering of HIV scientists, we know that our work provides the foundation for the global HIV response. So we're going to start to my left, Dr. Frank Demarco. Frank is the Senior Director at Janssen and the franchise clinical leader of HIV vaccines. He will present some encouraging news on the progress of HIV vaccine development. Over to you, Frank.
Thank you. And thank you for this opportunity. I am Frank Tanaka, and I am the clinical leader of the HIV vaccine programs at Janssen, which is part of Johnson & Johnson. And it's a great privilege for me to have this position. I started my career as a HIV treating physician for 15 years, and then 13 years ago went into development of antiretrovirals, and then 6 years ago have received this once-in-6 lifetime opportunity to work on this vaccine with an amazing group of global partners. Just a little background on what we're setting out to do with our HIV preventive vaccine program. We want to develop a mosaic-based vaccine to prevent HIV of multiple strains or clades. Our goal is to develop a global vaccine, and that this is what would happen if we could prevent multiple strains or clades. Mosaic vaccines refers to the immunogens or antigens, which are the molecules that induce the body's immune response. And these mosaic genes are created using genes from a variety of different strains or clades of HIV that circulate around the world. Today, what I'll be presenting at an 11 o'clock oral symposium is the follow-up data post the vaccination period in the APPROACH study. This was the first clinical study to investigate this vaccine concept. It was conducted in 393 healthy HIV-negative adults in the U.S., Rwanda, Uganda, South Africa, and Thailand. The initial data, which was data from week 52, 4 weeks after the final and fourth vaccination, was presented at IAS, the initial data, in 2017. A more detailed summary of this data is available in a manuscript that was published in The Lancet earlier this month, and I would refer you to that for details up until week 52. So my presentation today is what's happened since the vaccination period in the year after the fourth vaccination. This new data provides the first insight into the durability or persistence of the immune responses induced by this vaccine. The key findings are all mosaic regimens evaluated had a favorable safety profile. There were no unexpected vaccine-related AEs, and all regimens maintained robust humoral, antibody, and cellular immune responses even after 1 year of follow-up. The most immunogenic of the different regimens that we tested in APPROACH was comprised of a mosaic viral vector called adenovirus 26, or AD26, as a double prime, and then boost with the same AD26 component with a high dose of a GP140 protein. This is an envelope protein on the HIV, synthetically produced. All volunteers receiving this regimen achieved a robust antibody response, which persisted 1 year post-vaccination. Also, a high proportion maintained a cellular immune response. So in summary, these data demonstrate durability or persistence of immune responses elicited by this mosaic vaccine regimen. The significance of this is this was key information for Janssen and our global partners to start the first large-scale efficacy trial of this vaccine concept in 5 sub-Saharan African countries. This study started in November of 2017 and is called Imbokodo, and this will test whether the vaccine prevents HIV infection compared to those who don't receive the vaccine or receive placebo, and the results are expected in 2021. Thank you.
Thank you so much, Frank. Our next speaker is Jean-Michel Molina. Prof. Molina, well known to all of us, is head of the Infectious Diseases Department at the St. Louis Hospital in Paris, where he works with immune-compromised HIV patients. He'll speak to us about findings today from a real-world study on the use of on-demand PrEP amongst men who have sex with men. Jean-Michel.
Thank you, Linda Gabriel. Good morning, everyone. So it's a pleasure to be here today and to give you some preliminary data of the presentation I'll make on Wednesday on a study that is sponsored by the French Agency for AIDS Research, INRS, which call Prévenir, meaning prevent in French. As you know, in France, we have conducted the INRS IPERGAY study a couple of years ago, showing the high efficacy of on-demand PrEP to prevent HIV infection among MSM. This dosing regimen has been approved now in Europe. It's been endorsed by Australian, Canadian, and British guidelines, but not everyone is comfortable with this regimen. And beyond the data from clinical trials, we wanted to provide additional data on the real-world experience of this on-demand dosing regimen for PrEP for MSM. The other objective of our study was also to show upscaling PrEP in the Paris region, how we could have an impact on the HIV epidemic among MSM in Paris, because Paris is by far the most affected area by HIV in France. So we started the project a year ago. Our goal is to enroll 3,000 people And people actually have the choice to use PrEP either on demand or daily. So we present the two options, and the participants actually make their choices. And they could even switch from one regimen to another during follow-up. So at this conference, we are presenting the first data on the first 1,600 people enrolled in the study to provide additional data on the efficacy and safety of these dosing regimen on demand. Interestingly, among the 1,600 people enrolled, 46% opted for on-demand, 45% for daily. Another time, most of them remain with their initial regimen. Those using on-demand PrEP had fewer sexual partners and fewer condomless sex acts than those using daily. That's the only difference at baseline between the two groups. When we looked at the use of PrEP during sexual intercourse over time, it's striking to see that when we assessed what we call the correct use of PrEP was the last sexual intercourse covered by PrEP, between meaning having a pill before and a pill after PrEP. The vast majority, more than 96% of the participants with both regimen use PrEP very correctly at the correct dosing. So that was encouraging, and that's probably due to the counseling whom these patients benefited during their visit at the clinic. In addition, we've seen that 20% of these participants also use condoms, meaning that you could use PrEP and also condoms in combination, and that's important in the current context of STIs. When we looked at the incidence of HIV in the two groups, daily arm or on-demand arm, we didn't see any breakthrough infection so far. So that's remarkable, and that shows that the incidence of HIV in this cohort is actually 0 today. What's also interesting was that the very low rate of loss to follow-up, and the retention was very good. Only 3.3 per 100 person years of the patients discontinue actually the study. And if we use the incidence of HIV we have observed during the Hypergay study in Paris, these great results will let us think that we have averted up to 85 new infections in these people. When we looked at sexual behavior, there was no major changes between the two groups. And regarding the safety of the regimen, nothing remarkable between the two dosing regimen. Again, PrEP is very well tolerated with only a few gastrointestinal adverse events. And during the study so far, no one actually discontinued the treatment PrEP because of a drug-related adverse events. So in summary, we think that this interim report of this open-label cohort study among MSM strengthened the case for the use of on-demand PrEP for people who want to use on-demand and who are not willing to be committed to a daily regimen. And I think this opens an option for men who would like to use this on-demand regimen, and we hope that this will help upscaling PrEP in this community, because we are still far from reaching the number of people that would need to be on PrEP in order to have a significant impact on the epidemic among MSM in our country. And I think I'll stop here, and I thank you for your attention.
Thanks, Jean-Michel. Next, we're turning to Dr. Akaran Hiransathakul of the Thai Red Cross AIDS Research Institute. Akaran is the lead author of the IFACT study in Thailand, which examined the use of PrEP amongst transgender women and looked at potential interactions between PrEP and feminizing hormone therapy. Over to you.
Thank you. First of all, I would like to thank the conference organizer for slating our work to be presented here in the press conference. We are very excited to have a chance to share this result with you all today. So I think that I was first off with the background is that I think it's an established fact by now that PrEP is among the effective method for HIV prevention. However, we began to have concerns over the efficacy of PrEP among transgender women because there are studies that show us that the blood concentration of PrEP among transgender women is lowered compared to non-transgender population. Now, I think we can maybe categorize into two main possibilities. The first one is that transgender women did actually have good adherence to PrEP, but there was this previously unknown drug interaction between the fertilizing hormones and PrEP. Or secondly, and quite simply, transgender women did have poor adherence to PrEP. Now, if that's the case, there's also a survey suggesting that it could be due to the fact that transgender women prioritized the use of fertilizing hormones over PrEP. So this comes back to the same issue again in that, in the sense that people are concerned over whether or not there are really drug interactions between these two medications. So from that point on, we established a study called IFACT to determine whether there really are drug interactions between the use of fertilizing hormone therapy and antiretroviral agents. For today, I'm just going to talk about the part of PrEP. And I think right off the bat, the important thing that needs to be noted is that fertilizing hormone regimens can differ between each country. For us, what we use is estradiol valproate, which is a form of estrogen, plus cyproterone acetate, which is a form of anti-androgen. For the results of our study, we found that the blood hormones concentration was not affected by the use of PrEP. So this essentially means that you can use PrEP and fertilizing hormone concurrently without the fears that PrEP will decrease the hormones level in your body to the suboptimal level. Now for the second part of our results, now this is a little bit trickier. The results we found was that there's a 13% reduction in blood tenofovir exposure in the presence of fertilizing hormone therapy. While I think it's great that our studies have shown this previously unknown drug interactions between PrEP, tenofovir to be precise, with fertilizing hormone therapy. There are definitely some key questions that need to be answered before moving forward with these results. For instance, does this interactions also occur in cells or in target tissue, rectal tissue, for example, which in most cases is the first site of HIV contact? Secondly, does this interaction also occurs in other fertilizing hormone regimens? And I cannot emphasize enough that fertilizing hormone regimens can vary depending on the region you lived in. And last but not least, the 13% reduction in tenofovir. We don't know whether this 13% reduction in blood tenofovir exposure in the presence of fertilizing hormone therapies means anything regarding the preventive effect of PrEP. So there are still some questions that need to be answered before interpreting these results. And for further details of the study, I will be discussing it in the poster discussion this afternoon. Thank you.
Great. Our next speaker, Dr. Sarah Brown. Dr. Brown is an associate professor of medicine at the University of California, San Diego, and president of Specialists in Global Health. Dr. Brown is here to share findings from a study on digital PrEP, which could provide a new way to monitor PrEP adherence in real time. Over to you, Sarah.
Thank you very much to the organizers for inviting us to be able to present at this press conference. So as we've heard, HIV infection, and as you know, can be prevented by pre-exposure prophylaxis, and that currently consists of one tablet containing tenofovir and M-tricytidine combined in a drug called Truvada, which is recommended to be taken daily. Medication adherence, which means the extent to which a patient follows the instructions of a healthcare worker to actually take that medication daily, is considered crucial to providing protection from the infection. We're really dealing in medication adherence with the old adage that medications don't work if patients don't take them. My group works in the area of medication adherence, and there are a number of problems in this area. We really need reliable measures that are based on medication ingestion. Currently, clinical practice still relies mostly on self-report, which is patient recall. We need to be able to have ways for healthcare workers to distinguish who needs support and who doesn't, so that we can distribute resources appropriately. When we get that support, we really need support that comes in near real time. It's how useful is it when we discuss in the clinic what may or may not have happened a month ago? And then finally, and I think most important, these things really have to be patient empowerment tools. Patients need to have access to their own data. They need to be able to look at what they're doing, determine what kind of support they need, and share that with chosen healthcare workers and friends who can help support their medication-taking habits so they can protect themselves from HIV infection. So our research works with a novel ingestion system that actually answers most of those needs. This system was developed by a company in Silicon Valley called Proteus Digital Health, and it is an ingestion sensor-based system that we're using with oral PrEP. So briefly, how does the system work? There's this tiny ingestion sensor that's 1 millimeter by 1 millimeter by 0.45. It's composed of minerals such as those found in vitamin supplements. The patient has to wear a monitor patch on the torso, and I can show you what that looks like. And they need a paired mobile device. So when the sensor is swallowed, it dissolves and communicates a unique code, similar to a barcode. This information is stored on the patch. Data is then transferred from the patch to the paired mobile device by Bluetooth technology, and then subsequently from there relayed to secure servers using encryption protocols similar to banking. So once this has happened, you can have people sign on to a secure website as long as they have patient permissions to access this data, and then they can view remotely how the patient's taking their medication. So we have been working with the system, and we adapted it for oral PrEP. The first thing we had to do is actually combine the sensor with Truvada. And we did this in a very simple way using a technique called co-encapsulation. And this is where you put the sensor and Truvada in a gelatin capsule. So it's a very simple technique, but before you actually start using it in clinical trials and clinical practice, you have to make sure it's equivalent to native Truvada. So the bulk of the data in the poster presentation that will be up this morning discusses the PK results, which show that the pharmacokinetic curves associated with the co-encapsulated formulation and that of native Truvada are equivalent. So what this means is, yes, we can use it clinically, and we can use it in clinical trials. So we currently have a clinical trial underway in a group of PrEP patients. In addition, the results we're presenting will show you an example of how this technology can take longitudinal medication-taking patterns, and you'll be able to see the pattern of a patient that takes their medication very regularly, who clearly doesn't need a lot of support, and one whose medication-taking pattern is much more chaotic and would need more support. Finally, we have some data which discusses how the patients have actually had a good experience with this system. So what are the important conclusions? Digital PrEP is available, and digital PrEP will allow real-time remote capture of medication ingestion for clinical use. This technology can provide longitudinal patterns of medication taking that can be used to facilitate differentiated care. And differentiated care, putting resources in the right place, is going to be crucial as we upscale PrEP. And finally, this near real-time data transfer means that you actually have near real-time adherence support, which is likely to be much more effective. Thank you.
Thank you, Sarah. The final speaker, Dr. Allison Rogers, Senior Lecturer in Infectious Diseases and HIV at University College London, and Clinical Director of Public Health at the Royal Free. She was the lead author of the previous observational study on HIV transmission among serodiscordant couples, known as Partner 1, and she will now share compelling new findings from the follow-up study known as Partner 2, which focused on gay male couples. So, Alison.
Thank you. I'm very pleased to be here today on behalf of the Partner Study Group to present the results from a late-breaking abstract that I'm actually presenting tomorrow, looking at HIV transmission risk through anal sex in gay men in the context of suppressive ART. So this is the Partner 2 study results. So Partner 2 is the largest study to look at HIV transmission risk through condomless anal sex in gay men. And although previous smaller studies such as Partner 1 in 2016 and Opposites Attract did report 0 cases of HIV transmission in gay men, the level of evidence for gay men remains less than that for heterosexual couples, really due to the fact that we haven't accumulated enough couple years of follow-up in gay men. So the aim of the second phase of the Partner study, Partner 2, was really to look at within-couple HIV transmission risk through anal sex during periods when condoms weren't used and the positive partner was on suppressive ART. So Partner 2 study recruited and followed almost 1,000 gay serodifferent couples, so one positive in ART and one HIV negative, from 14 countries in Europe. And during that time, we accumulated almost 1,600 couple years of follow-up. And in order to have eligible couple years of follow-up, you had to meet certain criteria. So the HIV negative partner had to test at the beginning and the end of the period of time. Positive partner had to be suppressed at all time points during that period. The couples had to have had condomless sex, and the negative partner didn't use PEP or PrEP during that time period. So just a couple of key results. During follow-up, both the HIV negative and positive partners had STIs in about 20% of follow-up time. Couples had open relationships. 1/3 of HIV negative men had partners in addition to their main study partner in 1/3 of cases. And couples had condomless sex a median of 42 times per year, so that was 3 or 4 times per month. But over the entire follow-up period, we accumulated approximately 77,000 condomless sex acts, which is a significant number. And in the absence of antiretroviral therapy, we would have expected a very significant number of transmissions to have occurred. So while 15 of the HIV negative men did become HIV positive during follow-up, by looking at the genetic characteristics of the virus using phylogenetic sequencing, we could very clearly see that their HIV infection had not come from their HIV positive partner on suppressive ART. So due to the very large study size, the precision and confidence we now have around this estimate of 0 is dramatically improved, such that the very worst case scenario, so the outer limits of the confidence interval, are really you'd have to have condomless anal sex for almost 420 years to even have one transmission. And that is the absolute worst case scenario. So I think in conclusion, Partner 2 study was specifically designed to find out whether HIV transmission could even occur in gay men when the viral load's suppressed. And despite couples having sex without condoms 77,000 times, we found no cases of within-couple HIV transmission. So I think Partner 2 data provides robust evidence for gay men that the risk of HIV transmission with suppressive ART is effectively 0, and supporting the message of the U=U campaign. And I do have to pay tribute to Prevention Access campaign for effectively promoting the science behind Partner 2 and other transmission studies so effectively. So thank you.
Thank you, Alison. Those are impressive numbers, I'm sure you'll agree, and quite a challenge put out there. So we'll take questions from the floor now. If you'd like to ask a question, as usual, please line up at the microphone in the aisle. When asked, could you state your name, who you represent, and also to whom you would like to direct the question, and please keep questions quite brief since I'm sure there'll be some interest today. Can you also just kind of cue to the side so we don't obstruct our online viewers? So thanks for that. First up.
Hi. Sorry. Hi, I'm Heather Berner from Medscape, and I wanted to ask Dr. Akerin, I'm sorry if I'm saying your name incorrectly. So I write for physicians. Tell me how physicians should counsel their patients around these interactions right now. Should they change anything? How do they talk to them?
Yeah, so but that's a very excellent point. And when we found out about the results from the study, this is among the first thing that we discussed in our team. So I would look at this as a two-part of the results. So the first part again is the part that's saying that the blood hormone concentration is not affected by PrEP. So I think this one is quite easy to interpret and to give counseling to transgender women that, okay, you don't need to be concerned, you don't need to pick one, you don't need to prioritize one over the other, you can use them along and don't need to be worried about your hormones level, which in most cases is what their priority is their hormone, I don't know how you call it, your physique, something like that. So that's all right for that part. But now the second part, as I said, is very tricky to interpret this one. I have not went into more details about it, but one of the, I would say, optimistic that we found from the result is that when the blood test was done and shows that there's a 13% reduction in the blood tenofovir exposure, even that reduction, the mean level is still at the previously published target level for tenofovir level to be used as PrEP. As I recall, it's around 92% effective according to the literature. So I think that's the optimistic side of it. But yeah, so the way we're going to approach it, I think we really need to be very true to the results. So I'm not going to say that, okay, you don't need to be worried about the PrEP efficacy at all. No, I'm going to say that, okay, there's a chance that there could be a reduction in it. We don't know it for sure, but there's some optimistic in that the reduction level is still at the target level for the prevention effect of PrEP. Yeah.
Thank you. Gus?
Thank you. Gus Cairns, AIDS Map. This is for Frank Tanaka. I've read the previous publication in The Lancet and about the parallel monkey study as well. It's very exciting news.
You're on top of things.
Having done that, are you able to speculate at all on how long, assuming that there is a sort of parallel between the results in monkeys and humans, how long a useful, effective immune response might persist in humans after the last dose of your vaccine?
No, we're not able to say because we didn't follow the monkeys longer. So we only have this data, but there is, we amended the protocol, the approach protocol, for a 5-year extension period. Mm-hmm. So I think that will be very rich data on what happens to the immune responses and will help inform us on when a booster could be necessary. And we've added those long-term extensions to two others of our phase 2A protocols.
Thanks. Michael? Sorry. I didn't actually see that microphone in the back.
Jeffrey Carr from The Economist. This is for Dr. Brown. I'm trying to work out how your system works. Is it some sort of little RFID chip that's in the thing?
No, it's not an RFID chip. I can show you the sensor, and I have a patch.
Right.
The sensor is made of minerals. There's layers of calcium, there's copper, and then there's a little bit of a very narrow gold layer. And essentially, when the sensor hits the gastric tract, it starts to dissolve, and there's an electrolyte change.
Ah, okay.
And that electrolyte change emits a pulse, like a barcode,
right,
which identifies it as an individual. So
gotcha.
You can identify individual medications, individual batches, and the time that signal gets issued out, it's stored on the patch. So all that data is stored on the patch. And when the patch comes into contiguity with its paired mobile device, that is all uploaded by Bluetooth.
The other technical question is how big is the detector, and how awkward is it to wear? Because you might end up with no response because the detector's not in range.
Right, so
you have to be compliant wearing the detector as well as taking the pill.
Can you maybe just give us a sense of size?
It's about this big.
Right.
So yes, I think that's a very good point. So that's one of the things we're testing. We've got a 65-person so far PrEP trial going on, and we're looking at, how good the system is. We've used it in tuberculosis. We know it's extremely accurate. We know that it's actually equivalent to directly observed therapy.
Right.
So we know we've got a really accurate system. Now we've got to look in different groups of patients and see how they use it and how they like it. But straight out of the box, so we had to develop this co-encapsulated formulation. But then straight out of the box, you can immediately see that you can differentiate patients' medication taking patterns. So I think it's going to turn out to be quite a powerful tool in supporting patients.
Thank you.
Michael?
Thank you. Michael Smith, MedPage Today. This is just, in a sense, almost the same question as Gus's for you, Dr. Tanaka. But can you can't speculate on the length of the immune response, but can you give me a sense of how immune responses to other vaccines compare with this? Just put it in a more global context. If I get a vaccine for measles or mumps, for instance, it's pretty nearly permanent response.
I really can't answer that because it's incredibly variable, the immune responses to vaccines. A lot of vaccines, common vaccines protect using neutralizing antibodies and provide coverage for a long time. Some of them require boosters, others don't. And with HIV vaccines that have been tested so far, as you know, there have not been that many. In the Thai trial, which is the only trial that showed any efficacy, the immunity was substantial after vaccination, but then declined rapidly. So that consortium has, I think very wisely, is testing that concept with a later injection, a later boost. But it's very hard to say. I would say it's impossible to say how long. But I'll tell you what our plans are, regulatory-wise, is that we would like to license with 2-year durability data initially, but we would like that to extend that to 5 years eventually. That may require a booster within those 5 years. That's what we have to determine, is when we have to boost.
Okay. Maybe I can just ask you, Dr. Becker, because of course you're involved with the other trial. How does this impact on, what sorts of results are you getting from your trial thus far? Obviously it's still blinded and whatnot, but are you seeing anything that makes you believe that a multi-clade vaccine versus a single-clade vaccine would work better or worse, or just put it again, trying to get context here?
So Michael, I understand with around durability, I don't know that this is really the sort of the depth and the breadth, the multi-clade versus the single-clade. I don't know that really has an impact on durability, but we did present, as you know, at IS 2017, the fact that we did have to add an additional boost to the HVTN 100 data, and so that was why 702 was then the efficacy trial. Sorry, we talk in numbers, apologies to everyone. The HVTN 100, remind you, and Michael's alluding to the current trial that is alongside in Southern Africa at the moment, that is based on the RV144 data. So it's a similar vaccine regimen that's been modified for a clade C region, and we presented the initial in-human data at IAS 2017, first at Durban and then at IAS 2017, which did show the need for an additional booster in order to enhance durability. And we modified the efficacy, the current pivotal efficacy trial that is on the go in Southern Africa, to take that extra booster. So it's a little bit of trying to sort of compare apples and oranges, so it's difficult to say. I think it's fair to say that both trials are going to have to unfold in front of our eyes with real-time immunogenicity coming in, and I think it's really important that both phase 2s or phase 1b2s are prolonging their follow-up so that they can inform the efficacy trials whilst they're in the field. And so the two are kind of moving in tango in parallel.
Super, thank you.
And I'll add, even one of our ongoing, this is under discussion, so it's not absolute, but we have an ongoing phase 2A study now called the Ascent trial, and we're discussing, and we will discuss with our partners, the possibility of boosting in that trial and not waiting.
And just obviously, just to add again for context, is clearly we do want to get to regimens where there are not the requirement for not too many visits back to the clinic patently, but in the meantime, really getting a handle on that efficacy is first prize, and then ultimately working towards getting a vaccine that doesn't require too many boosts in the long term is the aspirational goal here. So we can definitely give more detail about these two approaches afterwards to anyone who's interested. Going back to the mic.
Hi, this is a question to the IAS, really. We've seen 6 amazing presentations of incredible research that hints at incredible research, and you've press released it before the conference has even had the data presented. It's completely unacceptable to expect press to report the quality of this research that has gone on for has involved years of investment by the researchers and the funders, and the community want to understand the full results before the headlines are splashed across the world in mainstream media. It's totally unacceptable. It makes our job impossible. We have to chase around presenters to try and get early access to data, and the result is bad science that doesn't respect the work of these scientists.
Duly noted. Thank you. Next.
Mitchell Zoller, Journal of Medicine News. Dr. Molina, could you describe what the on-demand prep regimen consists of?
Sure. Well, it is similar to the one we've been using in the Ibergay study. You need to start with a loading dose of 2 pills of TDF-FTC. Now we're using generic drugs because we have these available in France. So it's a loading dose of 2 pills that you have to take between 2 and 24 hours before sexual intercourse. And from that time, or the first pill intake, you have to take 2 pills after sex, the first 24 hours after the first dose intake, a single pill, and then the 4th pill 48 hours after the first drug intake. So for one sexual intercourse, it's 4 pills, 2 before together and 2 after, separated by 24 hours.
And regarding the Thai study, did you see any effect on the emtricitabine?
The emtricitabine, right? Unfortunately, we did not measure that. It was not very feasible for us to do it.
One more.
Hi, Steve from Stellenbosch. Just a question for Dr. Brown. So if I understand correctly, this system could really empower patients who are forced to take a handful of pills for a variety of concurrent conditions, who perhaps drop one on the floor, that these patients, when that handful of pills reach the stomach, the system can pick up which pills arrived in the stomach simultaneously and which one was dropped on the floor. I mean, if that's true, that's hugely empowering to patients who are on perhaps complex regimens for resistant HIV plus resistant TB plus etc.
Yes, it is true that the sensors are aligned with individual drugs. They get coded with individual drugs. So you can distinguish multiple different drugs when they are swallowed simultaneously. So yes, that is true. It does have that facility, and we are starting to use that in trials.
Okay, seeing no more questions, I thank you so much again to our media partners for being here today, and of course, warm thanks to the panelists and everybody who will be presenting their data. As usual, I'm sure everyone will be available for more in-depth conversations if needed. Thank you. This conference is now over.
Thank you, Demarco.